strong in managing yourselves and your various disease conditions as you proceed. Oh, Kathleen, can I have a little bit of water? Kathleen was right. She figured that I might need some water because I get this way when I start talking. So, um, you as folks who are involved in the field of dialysis and transplantation, as folks that are involved with people with kidney disease that may be going for a kidney transplant, waiting for one, or have already received a kidney transplant, maybe caring for somebody with kidney transplant or dialysis, either in your dialysis facilities or in your home dialysis program, or in your homes as a caregiver, as a family member. Thank you. You're all very, very um, um, resilient and want to maintain your knowledge about everything that is going on in this field because the news changes every day. And what I wanted to talk about was also what a wonderful thing it is for us to be right now in Ohio, where our governor took some very important steps along with our public health director, Dr. Acton, to clamp down very early and stem the course of the epidemic in a way that was not possible for places like New York. What you hear from New York are tales of despair. You hear tales of the system getting overwhelmed, that the hospitals are not able to take care of patients. Rest assured that in Northeast Ohio, with the wealth of institutions that we have around us, and UH being one of them, we have a wonderful medical community, and we have organizations like the KFO that have come together to help people. So where I'm going to focus my presentation is to leave you at the end of these few minutes that we have together, is some understanding of what happens when this COVID-19 virus comes into our communities and into our bodies, and what happens when the body tries to fight, what the disease looks like, what we can do to prevent ourselves from getting afflicted by this, what is being done by health systems to move forward, and especially what it is like to be dialyzed or waiting for a transplant, evaluated for transplant, either as a recipient or as a donor. And if you're a recipient of a transplant, how do you cope? So let's start with the elephant in the room, which in this case happens to be a virus. It's a large enveloped virus that is endemic globally. When we say endemic, it means they're everywhere. And it accounts for about 10 to 30% of the common cold, which is the coronaviruses in general. But there are some forms of this virus that cause more severe disease, which are what they call the severe acute respiratory syndrome viruses, or the SARS viruses, of which COVID-19 is a form. These viruses are not necessarily human viruses, and they can be in bats and very domestic mammals, which can serve as intermediate hosts. Next slide, please. First thing, it's not a common cold on steroids. So when this whole thing started around January, we had a patient that tested positive on a nasal swab. It turned out to be the standard coronavirus, and I just shrugged it off and said, hey, it's just a common cold. Well, that same week, we started getting reports of the novel coronavirus. Luckily, our patient was not that sick. We took care of the patient and everything went well. Usually, it's a mild and self-limited disease. And previous examples of increasing levels of threat included the Middle Eastern respiratory syndrome, which you heard of years ago, and the Southeast Asian respiratory syndrome virus, which occurred almost 18 years ago. It's what we call an atypical pneumonia that progresses rapidly with what we call ground glass opacities in the lungs, and they may not be visible on the routine X-rays. And it represents both an infection and actually a host response to the virus. In other words, your immune system is fighting this virus, and it's essentially fighting it with everything that it's got. And it fights it with the same mechanisms that make a kidney transplant reject. So it fights it with extreme vigor. And What it does there is causes lung damage very rapidly, and that causes patients to progress. And this is something that folks learned the hard way, that there's these lungs are leaky, that you can easily flood them with fluid, and you can also have microclots in the lungs, vessels that can leave cavities, and the vessels in the heart can be affected too. So patients may present with chest pain, think they're having a heart attack, and yes, they could be having a heart attack because you could actually have things going on in your heart. Um, and then multi-system organ failure ensures can issue. In other words, we can have failure of the lungs, heart. We can have kidney failure, and also issues relating to clotting and liver problems in these patients. And so these folks can get sick very quickly absent care. Next slide, please. So what does this thing look like? Why is it called a coronavirus? So you see on the you see this round blob, which is gray for the most part. Then you see these pink spikes on the periphery of this virus, which look like a crown. That's why it's called the coronavirus when they first found it in the 50s. It's about 90 nanometers, or a billionth of a meter across. And when you say a billionth of a meter, it's about 1/millionth the size of the lung cells that it infects. It's got 4 proteins and a strand of RNA, which, like DNA, can store genetic information as a sequence of chemical letters in its code. These are called nucleotides. It also includes instructions on how to make all the other proteins the virus needs in order to copy itself without carrying along from cell to cell. Next slide, please. So this is what it looks like. It's the RNA part is much bigger than HIV. It's much bigger than influenza, a little smaller than the Ebola virus. And it's got what are called structural and non-structural proteins. Non-structural proteins are what helps this virus make itself and hijack the host cells. And it's got a whole bunch of other things that make these structural proteins. Can I go back to the previous slide? So essentially, they have something called a spike protein, which is what you see coming out on the outside, which look like little push pins that are put in. And it mediates the attachment of the cell of this virus to our lungs and also to the kidney. The lipid membrane, which is there on just inside, can be disrupted by detergents. In other words, soap and water, hand washing works to kill this stuff. And there is a scaffolding around which this thing wraps its RNA. And I'm seeing all these things to you because these are all various targets for drugs or disinfection or other procedures that can target the virus. So you have an idea of what the logic behind the various treatments is for this condition. Next slide, please. So what does it do? This thing is a very good hijacker. What it does is, on the left, start from the left as we go down the steps. It starts with the virus particle that attaches to a receptor called the ACE2 receptor. And it then engages a protein, which again it hijacks, that is a protein that's in our cells that helps this virus get into the cell. And then it then hijacks its non-structural proteins, take over, and it starts making copies of itself. It goes into this chemical machinery in your chemical factory in your cell called the Golgi apparatus, where multiple copies are assembled, and this thing then gets out of the cell membrane and can infect other cells. So when you go from left to right, you start with adhesion to the cell, getting into the cell, hijack the cell machinery to make copies of the virus, wrap itself up in the host protein, which basically host membrane, cell membrane, which basically gives it that lipid layer or the fatty layer, which can be disrupted by soap, but then it goes out and infects the other cells. So that's how it does this. And put into that, and when all this is going on in your body decides to attack the cell, and therefore it will end up causing damage both from the infection and from the immune response to it. Okay, next slide, please. So I showed you various ways uh, uh, in which this protein can go, and in which this virus uh, replicates or attaches, and what it can do in the body. And so you would assume that the treatment could be targeted at various sites, which disrupts this virus. So you've heard in the news about a drug called hydroxychloroquine, which has been extremely controversial. This acts potentially on the Golgi apparatus. The jury is completely out on that drug. Trials are ongoing. A drug which was used for HIV, which is Kaletra, has been used in some centers in China. Interferon can be used to modulate the immune response, but again, it's controversial. It is only being used in desperate situations. Now, remdesivir is a drug that's come out that acts on as an analog to the building blocks of the RNA, and therefore it disrupts the ability of this virus to replicate. Favipiravir is a drug that is active against influenza, which may also work for this, which is being tried out in clinical trials. With regard to the host immune response, there's two drugs that are become gained prominence. One is called tocilizumab, a brand name of Actemra, which is a rheumatoid arthritis drug that has been used successfully in some pretty severe situations. We've used it across all three institutions at Cleveland, at the UH, at the clinic, and at Metro with good results on some of the patients. And so that's something that's used in patients that are about to decompensate or have established disease. So this is something that is being provided to patients in this area, and we are very fortunate to have adequate supplies of this drug. Active clinical trials are also enrolling across all our institutions in Northeast Ohio. So we have many from a epidemic, which became a pandemic that started in December in China, to where we are in May. We already have multiple treatments on the horizon. And because of our information technology, just as the virus spread so rapidly across the world on airplanes, cars, people traveling, and everything else, cruise ships, information also spread rapidly. And we are now at a point where we are able to take care of patients very well and have very good practices with regard to this. So rest assured, if you're a patient or a caregiver or a family member, that there are multiple resources available for your patient. Next slide, please. So the transplant programs responded very early. And we obviously took the first step out of an abundance of caution to suspend living donor transplants because we didn't know how the virus was going to behave. We used judgment and shared decision making with regard to acceptance of deceased donor organs, because it is not a fun place to be on the wait list, because being on the wait list is also a very risky place, because you know that you can get sick very rapidly and you may not be a candidate. Good Kidneys came along, both programs in the city accepted those organs and transplanted under caution. We all converted most of our visits beyond the first 90 days post-transplants to telephone visits or telemedicine visits, and we initiated triage protocols in sync with our institution. What is wonderful about the Cleveland transplant community and the dialysis community is that very early into this, UH, Cleveland Clinic, Metro Health, the VA, DaVita, Fresenius, CDC, and other providers of dialysis all got together, and we maintain a cadence of calls every week to make sure that we all have enough capacity for dialysis, and we have enough capacity to take care of our transplant patients, have rapid sharing of information. If a patient were to go to an institution that is not their home institution, but the patient would get that care in a way that did not happen in New York, where they were not talking to each other. So, and this, in Northeast Ohio, where we're doing this way before we came to know about the problems that kidney patients were having in New York. So again, a great place to be. Along with our Shutting down of routine surgeries and routine procedures and routine visits in the clinic. We had an extensive local expansion in testing capabilities at UH, Cleveland Clinic, Metro Health, VA, and Quest Diagnostics, which made it possible for people to obtain testing if they need it for COVID-19. Next. So if you're a transplant patient, the first thing I'm going to tell you, don't stop your immunosuppression because you want to prevent infection. Just because you're afraid of COVID and stop your immunosuppression does not mean that you will not reject your kidney. Tacrolimus and cyclosporin can be continued unchanged unless overwhelming secondary infection is seen. Some of the drugs like Kaletra can interact with the tacrolimus, and doses may need to be modified. The Cellcept and Myfortic were being held by most programs or reduced in dose. Prednisone may be continued unchanged. In fact, some patients may be given a boost in the steroids. Tocilizumab may be life-saving. Sirolimus and everolimus theoretically may worsen pulmonary congestion syndromes and or impair healing. So it should be their continuance or discontinuance should involve physician advice. If on nebulized pentamidine, or if you're asthmatic, or if you have a relative that's asthmatic, one would need to consider this as an aerosolizing procedure if you're using the nebulizer. And if you're on nebulized pentamidine for prophylaxis against PCP, one would think about converting to atravaquone or use airborne precautions when taking those nebulizer treatments, either at home or in the hospital. Next slide, please. Maintain hydration. It's absolutely important to maintain hydration. Maintain an adequate supply of medication. Do not miss lab appointments because that may be the first clue that something's going wrong. Speak with your center about remote lab draws and monitoring. Symptoms may be milder with immunosuppression. Maintain contact with your transplant center through telemedicine. Establish a buddy system so that somebody's doing well checks on you and make wellness checks on you and make sure that you're staying well. And if you're isolated at home, make sure that you have somebody that's looking after your health and who's responsible for calling on you so that if you get sick, you have somebody who can take you in the medical care or who can help at least call EMS or do something like that for you. Absolutely shelter in place with social distancing and masking. Please take masking and social distancing absolutely serious. And apply hand washing with soap and water. This is your best friend. And if you're having to go into work or having to use a public computer, please wipe down keyboards, mice, things like that in your workplace with approved disinfectants, wipes, and with the appropriate precautions and hand washing between these things. And this is absolutely going to be your best friend as you move forward. And it's also going to be your best friend at home. So even though you live with people, anybody is at risk of getting infected. And it's very important for us to do this. Okay. Next slide, please. In-home lab jobs are being offered by multiple proprietary programs in addition to working with your transplant center. And there are local home care resources that can be used. Please note that there may be some resource and ordering constraints and they vary from institution to institution, but certainly speak with your transplant center about the options and how they're connecting with you remotely and following these labs. Next slide, please. For the waitlisted patient, please don't forego monthly lab draws. Observe precautions in your dialysis unit and your life in the community, social distancing, hand hygiene, masking. Do not be polite about things like that. Symptoms may be very mild. Discuss offers as you would normally with your center and your doctor. I'm talking about offers, I'm talking about organ offers. Please don't be afraid to come in to get transplanted if the organ offer looks good and the cross match looks good, because we are taking evident precautions in the hospitals to limit the number of patients, limit the number of visitors. And also when these donors are being tested by various organ procurement organizations, they're screening donors and practices vary by OPO, but believe me that testing is being offered either on nasal swabs or bronchoalveolar lavage fluid, some with blood testing, and screening by CT scans for absence of pneumonia. We have not had any transmission in this area related to transplanted kidney or pancreas. Next slide, please. In the transplant episode, we do have visitor restrictions. We encourage everybody to stay in touch remotely. Maintaining distancing and precautions after discharge is very important. Making sure that you have caregivers that comply with precautions is very important. Again, do not miss any lab draws or dialysis if needed. Maintain adequate supplies of food, water, and medicines. Strict adherence to hand hygiene, masking. Fever may be suppressed by immunosuppression, so that's something that you need to keep in mind. Your phone is your absolute lifeline. For heaven's sake, please keep that charged. Make sure your plans are up to date and use that absolutely as your lifeline. Next, please. After discharge, please maintain your lab schedule. You can use home lab draws, maintain clinic appointments with precautions, or stay engaged with telemedicine. Keep logs of vital signs. Have a network of caregivers that can help if one or the other person falls sick, because that can happen. And maintain distancing if family members have to go out to work. Next, please. With regard to sick contacts, self-quarantining and distancing is very important. Masking is absolutely important. Testing is offered at all the major medical centers in Cleveland and Quest, so please use those resources as you may, in conjunction with advice from your transplant center and your primary care physician. For living donors and recipients, operations will resume over the next week or two at both centers in the city. Evaluations are ongoing virtually out of an abundance of caution. We are requiring 2 negative tests, at least at UH, 1 week and 48 hours before the operation. Status of antibody on determining the risk is uncertain. The National Kidney Registry is also pushing towards parent donation, resuming very quickly in full swing. So these are things that are evolving topics that I would urge everyone to stay in touch with their transplant center, their physician, their primary care physician, and make the right decisions for themselves and their family. Next, please. In conclusion, I would say COVID-19 has allowed our community to come together and to further appreciate the beauty that is transplant. And also, what a wonderful place. If you have to be somewhere in the middle of a pandemic and be worried about something like the COVID-19 virus and its consequences, Northeast Ohio is a good place if you need medical care, because all the institutions work well for you, and you have wonderful community partners like AFO who are out there for you in helping you navigate through some troubled waters. We will go forth into an environment that is far safer than you ever encountered. You as caregivers in the ESRD world, as transplant patients, as wait-listed patients, as dialysis patients, are already there as successful participants, because the people that have good hygiene practices are the ones that are long-term survivors in our world. Telemedicine and innovative care pathways emanating therefrom will define our future. And I said, Cleveland and Northeast Ohio have never been safer as environments to need or receive a transplant, and all the institutions in this area are at your service. I will conclude here and ask you for your questions and would welcome a discussion.
Okay, this is Molly. Thank you so much, Dr. Srinivas, for that wonderful presentation and valuable information. I'm just waiting. I'll give it a minute. If you have any questions, please submit them through the chat feature. I'll give it a minute just to see if any pop up. If not, I have a couple. So, thank you.
Hey, I'm not using a mask personally because I don't know what it does to my voice on the phone. So I'm not trying to be Mike Pence here, okay?
Mm-hmm. Okay. All right. I have one question. So you had mentioned in one of your slides that patients who are currently taking immunosuppressants are actually experiencing a potentially less severe reaction to COVID. Is that because there's a lack of a cytokine storm? Are the immunosuppressants actually helping to protect transplant recipients because of the immunosuppressants?
Beautiful question here, Holly. So, the question are is the immune suppress is the suppression of the immune response helpful in combating COVID? And if so, are the patients expressing less of that surge of the molecules that mediate the immune system called cytokines? The cytokines are small molecules that are produced by immune cells in reaction to pathogens, which are foreign protein, and they cause various things. They cause white cells to go to places where they mediate inflammation. They can cause leakage from blood vessels. They can promote a clotting environment. They can drop blood pressure and do all of those things. When those things happen in a huge amount, it's called a cytokine storm. And that is responsible for the decompensation that a lot of these patients face. And it is possible that some of this response may be curbed by the immunosuppression, but at the same time, it is also felt that in the early phases of infection, it's not very well known what exactly happens, but it is possible. We did not see the kind of rapid decompensation occur in these folks. It did happen in cities like New York, where I think people were so closely packed and dense about this, but it was actually uh, an interesting part that we've not actually seen that in our region, where we've been able to take care of folks with immunosuppressive regimens. We've also been able to use the tocilizumab to prevent the cytokine storm and manage people accordingly. So yes, short answer, yes, the cytokine storm may be milder in these folks, but it can be variable from patient to patient.
Okay, great. Thank you. A couple questions from the audience from Margaret Baker. When will dialysis patients who are interested in transplantation be able to start the evaluation process?
So so we've restarted our evaluation process. We're doing telemedicine right now, and we hope to be fully up and running by the 15th of May, where we start bringing patients in, and we can start bringing in patients in for radiology tests and things like that. I'm already, so we've been doing telemedicine visits where we've been interviewing donors and recipients and also waitlisted patients by webcam. And those have been going well, but obviously nothing substitutes the human contact that all of us desire as patients and as caregivers, because I did not go into this profession to be a Zoom doctor, right? I meant to be a doctor. And so I think this is something that's going to start very soon. Rest assured that we are coming back towards normalcy. We just wanted the institutions use this period as a period to gear up to make sure that we're able to provide the kinds of precautions that you must enjoy as a recipient or a donor to be transplanted safely.
Okay. A couple more questions. What is the timeline for new referrals to get waitlisted right now?
So it depends entirely on how well prepared you are. I can tell you that if you have your colonoscopy done, if you need one, if you have your mammogram done, if you need one, if you have your pap smear done, or a PSA and the stress test approved, and everything is up to date with your wellness with a primary care doctor, and you come in for an eval today, I can get you listed or looked at for living donor that week itself. Okay, but if there is a delay in those kinds of things, that's what holds us up. It's not that there's a delay in the eval process so much as the things that need to be done as part of the eval process. And that's usually the cause for delay. And if there's something, so there's no delay per se because of COVID in that. It is just a question of whether a person is ready to be activated.
Great. Another question, has there been any regional differences throughout Ohio or the US between the decrease in living donor transplants? Is one particular center or region being more proactive or not?
So most centers have clamped down on living donors, regardless of where they are in the country. California picked up a little bit. Deceased donors have been going on in most of the country. New York slowed down a lot. Detroit slowed down a lot because of their epidemic. But those centers are back online. We encountered an increase in the number of transplants that we did as those programs slowed down, because kidneys, as you know, are shared nationally. We've had an unfortunate increase in the number of opiate deaths during this period. And so we've actually had an influx of deceased donor organs, some of them of really good quality, which have been gone to some very fortunate people. And so it's been variable. There are regional differences. The sad regional difference that is coming out is that in parts of the world where care is poor to access, in other words, places like Louisiana and places like that, where there's a lot of poverty and scarce resources, the mortality rate has been pretty high for people with kidney disease. So that's not a fun place to be at if you're living in places like that. New York and clearly places like Detroit have had major resource constraints, and we are in a region which is abundant in terms of its resources, both in terms of ICU beds and also in terms of our personnel and the capacity of our institutions to accommodate patients. So we have not had that kind of constraint.
Great. Another question, do you anticipate a greater availability of organs as a result of the number of deaths related to the COVID virus?
So if they're related to the COVID virus and attributed to COVID, we cannot use those organs.
Okay.
Right? Mm-hmm. So that's a very short answer there, because the virus does circulate in the bloodstream and the virus does infect the organs. And we don't know what it's like to give, we don't want to transplant COVID to an organ. So anybody that's giving up an organ right now cannot do so in the context of a COVID-related death, which is one of the reasons why we suspended lung transplants. We continue to do hearts, we continue to do some livers, and we continue to do some kidneys. But we suspended lung transplants during this period for fear of either transmission of COVID to a newly transplanted lung or transmission of COVID through the transplanted organ itself to the new recipient in an infected lung.
Okay. Another question, as a living donor, are we at any greater risk for infection? And as the transplant recipient is in the same household, knowing symptoms such as a fever, given that those symptoms can be suppressed or remain hidden, are there any specific symptoms changes to watch for?
Great question. So typically, the living donor, the operation itself should not increase the chances that the person may get COVID. However, the fact is that you are coming into contact with, a living donor typically goes back to work very easily, very early. So they do come into contact with the community, and so they can catch things as they go out. The recipient tends to be much more protected and stays at home typically for the first few weeks to months after transplant. And yes, the symptoms are milder. At the same time, one needs to watch for a dry cough that doesn't go away. One needs to watch for feeling poorly and getting short of breath. Pulse oximeters are available on retail. Those can be bought, and they can be actually used to monitor people. Okay.
Okay. I had a question. I have read some articles about how there are at least 12 different strains of COVID floating around the world and around our country as well too, and that some strains are more or cause more severe reactions in people. Do we have any idea of what particular strain is in and around the Cleveland and Ohio area?
So that's a great question. I'm afraid I'm going to have to confess some ignorance here on that, and I'll have to. I don't have an infectious disease specialist on it, and I can certainly supply you somebody who is much more knowledgeable about that to do a talk on that if that is desired. I do not know the answer to that, but certainly the effort that everybody's putting towards right now is to have treatments that are effective very broadly. So regardless of strain, so they're going after the mechanisms of the viral replication understanding what we know about the genome of the virus and trying to apply that treatment. And typically we think about treatment as being one agent. We may see an emergence where we have combination regimens that are being used just for that particular uh, happenstance or scenario that you detail about the strains, because various strains may be more susceptible to one or the other approach to treatment.
Okay. And then one more question. Do you see any long-term consequences of COVID-19 on transplantation?
Absolutely. I think the first thing is that they have one more virus that we have to test for, as we've been testing in the transplant. So testing is a very um, um, foreign concept for a lot of people in the transplant community, whether it's a living donor transplant or a deceased donor transplant. Testing for viral pathogens and some bacterial pathogens is standard. It's part of our normal workflow. This is going to be one of those viruses that's going to be added to that standard workflow. We're going to have some questions related to disease of donor acceptance, donor triaging, recipient triaging. The way we take care of patients by telemedicine, I think all of us have become much more comfortable with it. Not going to replace physical visits, but we become much more comfortable with it. I think as a field, we'll become much more comfortable about learning from registries of relating to COVID that are emerging. We'll learn much more about how these treatments are to be applied in the context of immunosuppression, effects of immunosuppression on organ function, how we handle sick patients, how we triage this. Absolutely, we're going to learn a lot more. And I think as a community, we're all going to come out stronger, because the dialysis, nephrology, transplant community is, and the community of patients, caregivers, and community organizations that are built around this are innovators and fighters by choice. Okay, we all do this, and we all do this well, and we come together. And so I think that coming together has been a wonderful sort of force in transplant, which has put this in the forefront. And absolutely, we'll go from strength to strength. I do see it being different, but I also see it winning in a very different way.
Great. One more quick question. What is the transplant staff doing to help protect themselves during this time?
So, great question. Transplant staff doing to protect themselves. First thing is that we moved most of our coordinators to remote locations. They're working from home and doing everything remotely. So we emptied our offices out. We maintain social distancing. All our meetings and selection committee meetings are all done virtually. We maintain 6 feet at least between ourselves. We mask ourselves. There's this triaging done at our institution at the right at the entrance, so that nobody who's got any sickness or fever is allowed to enter work. We have hotlines to make sure that anybody that's sick or potentially related to COVID is promptly being sent home to self-quarantine, get tested, and appropriately evaluated and triage. And I'm glad to report that we do not have a single person, at least in our program, that has fallen victim, touch wood, to COVID so far.
Great. Well, that's wonderful information. And then one other question just popped up. Are you anticipating seeing a big increase in the transplant wait list because of the temporary postponement of transplants?
So the transplant wait list, there's 2 parts to this. One is obviously we had a postponement, and then you'll start putting those patients on the wait list. So yes, it'd be an increase, but that would be what we call a bolus effect related to a temporary perturbation or something. The bigger thing that needs to be watched for is whether the actual number of patients going to need who have end-stage renal disease that was triggered by a COVID-19 infection among the survivors. That's what we are watching for, and to see whether that will be going. And we would also obviously need to look at what kind of lung damage is left long-term in these patients who survived COVID-19 and who may have kidney failure, and how long it takes to recover, and what we need to do if they test positive, because people can get reinfected, is what we're finding out, and whether they have antibody and what can be used in terms of the convalescent serum and things like that. So those are all big open questions, and I'm not so sure that we know the answers until we start seeing those numbers from the Scientific Registry of Transplant Recipients, which I'm sure we'll have those numbers from UNOS and the SRTR in the weeks to months to come.
Great. Okay, give it a minute. Any final questions? Please submit them right now so we can ask the doctor. All right. And if there are no further questions, thank you so very much for your attendance today. And thank you, to Dr. Srinivas and Kathleen at the UH Transplant Institute for providing such wonderful information. It's incredibly valuable, and we hope that you find it valuable as well too. There is a very brief poll to be answered at the end of this. It should be showing on your screen right now. So please join me again in thanking Dr. Srinivas for his time and valuable information this morning. We thank you for attending. The slides and webinar will be available following this session. If you have any questions, please don't hesitate to reach out to us at the KFO. And thank you again, Dr. Srinivas.
So thank you. I had to unmute myself. Okay.
And that concludes today's webinar. And again, any questions, please don't hesitate to reach out to us at the KFO. And thank you again. Have a good day.